I've got the pleasure of introducing Dr. Evangeline Wassmer. She's a paediatric consultant in Birmingham Women and Children's Hospital, and in 2004 she set up the first paediatric MS unit in the UK, so I'm sure she's got an awful lot to tell us, and she's going to be talking to us today about demyelinating disorders and MS in the paediatric population. Thank you.
So, thank you for the invitation. It's really a pleasure to be here. And I appreciate always the adult MS nurses, because when we started in 2004, we used to borrow the adult MS nurses who worked in a different trust because we didn't have a nurse, but we do have our own nurse now. But it was really helpful to get the support of our MS nurses. So I'm hoping today to clarify what was a complex and challenging disorder, these demyelinating disorders in children, by asking following questions. And I have really simplified it, and I'm sorry if it's too simple, but you can ask the complex questions afterwards. So I like stories, so I'll introduce you my first story, which is a 4-year-old boy who woke up one morning with fever, headache. He was a little wobbly on his feet, and he had a sore throat. So he went to see his GP, was diagnosed with tonsillitis, and was given a course of oral antibiotics. Unfortunately, he didn't get better. In fact, he remained miserable, wasn't talking, and was off his food. And then on day 6, he had a seizure, and so he came to hospital. Now, given the story of having a fever, being drowsy, having a headache, the first thing that comes up in a pediatrician is, oh, this must be meningitis encephalitis. So he had a lumbar puncture done. And they did do oligoclonal bands, which is very unusual, but because they don't normally do them straight away as a pediatrician. And those were negative. We didn't know that result. But because the CSF didn't look inflammatory, they decided, okay, still not better, let's do an MRI scan. And when they did the MRI scan, it showed demyelination. And you can see here these very large, fluffy, white matter lesions, but it's also not just affecting the white matter, it's also affecting the deep grey matter. And this is quite typical MRI scan for a condition what we call ADEM, or acute disseminated encephalomyelitis. It's a bit of a mouthful. And he was given a course of methylprednisolone, and he made a full recovery. Later, we found out that he was MOG antibody positive. So what is ADEM? It is acute disseminated encephalomyelitis. It usually presents 7 to 14 days after infection, usually with polyfocal neurology and encephalopathy. That's, an unsteady gait, some blurred vision, weakness, double vision, seizures, headache, and a reduced conscious level. And they can be extremely sick patients. So these children are not, many times land up on the intensive care and need a ventilation. But the outcome is good. Many of them make a full recovery, and it is usually monophasic. So this is it. This is the demyelinating event. They respond to steroids. So the MRI scan looks a bit like this boy scan, where they have these diffuse, bilateral, asymmetrical grey and white matter lesions. And when you do a follow-up scan, most of the scans, usually about 3 to 6 months afterwards, all of those lesions are gone, and the scan looks back to normal. Sometimes it's partial resolution, and it does leave a bit like a scar, I say like a print, that, a reminder that you've had ADEM. So ADEM is one of the inflammatory demyelinating diseases that we see in children. Other ones are the clinical isolated syndromes, like transverse myelitis, optic neuritis. And we also see the relapsing ones, which is MS, NMO, and the newer one, which is called relapsing MOG-associated demyelination, which used to be known as multiphasic ADEM or ADEM optic neuritis or relapsing optic neuritis. This is an old flow diagram, and if you've heard me speak before, I'm sorry, I'm bringing the old slide back, but I really like this flow diagram because it really simplifies and really highlights the differences between these different demyelinating disorders. So when a child with demyelination has an encephalopathy, so they're drowsy, miserable, unresponsive, and the EEG is usually slow as well, this is ADEM. And when a child has no encephalopathy and usually just has one neurological symptom, either they're unsteady or they're weak, then it's what we call clinical isolated syndrome. And these are the children that are at risk of having relapses and having MS. It's children that present with optic neuritis and transverse myelitis, and if they often relapse as relapsing NMO, and that's often associated with the aquaporin 4 antibody. Now, ADEM generally doesn't relapse, but it can relapse. A small group of them relapse, and that is called multiphasic ADEM, or if they relapse with optic neuritis, it's ADEM optic neuritis. We're not very creative in our names. And many of these children have MOG antibodies, and that's why it's now called MOG-associated demyelination. So let me introduce Daisy. She was an 11-year-old girl. She was sitting at school, and all of a sudden she noticed she couldn't speak. It was lunchtime. So it might have happened a bit earlier than that, but she wasn't speaking because she was listening to the teacher. But when she was having a lunch and having a break with her friends, she couldn't speak. And then over the next 2 hours, she got a very slowly progressive weakness of the right arm and then of the right leg. And by the time at 4 o'clock, she was walking home, she really struggled to get home. Of course, her mother took her straight away through the A&E department. And the first thing, of course, they did was they tried to do a CT scan, but there was a slot for the MRI scan. So off she went to have her MRI scan. That's actually quite unusual. And on the scan, they showed these very well-defined, small white matter lesions. You can see there a nice little cuff around it, and it's periventricular, pericallosal, and this is consistent with a scan which you would see with multiple sclerosis. We did do some more tests, as she was only 11, wanted to make sure we got the diagnosis right, and she had some CSF, and she had oligoclonal bands which were present. We did EBV serology, her IgG was detected, and she also did her antibodies for MOG and aquaporin 4, they were negative. So all of this really is consistent with MS. So she was given acute treatment, IV methylprednisolone, and she made a full recovery on discharge. And after that, she was thinking about what disease-modifying treatment to start. Eventually, she was started on Tecfidera. Now, if she was post-pubertal, she's 11, she was post-pubertal, so we were able to give her Tecfidera. If she had been pre-puberty, we would have only had one option, and that is Rebev. So pediatric onset MS is very similarly as adults defined. It's 2 or more clinical attacks separated in time and space. And to make the diagnosis earlier, you can use MRI or oligoclonal bands. And this is what it's a similar criteria we use, and this is really helpful for the older child above the age of 11. For the younger child, which thankfully there are very few of them around, you just have to really be a little bit more careful making the diagnosis. The presentation and the MRI scans aren't always that typical, and we do a much broader set of investigations just to make sure we got that right. So let's talk about these 2 girls. These are 2 girls that, these are all basically children that I've seen in the last year, so I just thought I'd make it a bit more helpful or interesting, and just show you a little bit of the challenges we have. So we've got Amy and Heidi. They both presented with headaches, and now because we're in 2022, we can do scans, and so these 2 children had 2 scans to reassure the family. It wasn't that reassuring because both scans showed white matter lesions. But the white matter lesions in Amy look very much like a scan you have with MS, whereas the Heidi's ones were slightly atypical. And so we called Amy a scan as, something called radiological isolated syndrome. We did investigate both children because the demyelination was raised and MS was suggested. And as you can see, most of investigations that Amy had basically confirm or are consistent with multiple sclerosis. And thankfully, or whatever, not thankfully, but then with a repeat scan, she had new lesions, so that confirmed the diagnosis even more. She also had a spinal lesion. We didn't do an MRI spine the first time round. And then 9 months later, she actually had a relapse. And so this is relapsing remitting multiple sclerosis. Whereas Heidi, we could reassure because all these investigations were normal. And even, I know Heidi for a while now, even 5 years later, she's fine. I don't see her regularly. Her mother just tells me now and then. She calls me and says, oh, she's fine. So virtual consultations, we've been doing them for years prior to COVID. So Heidi doesn't have MS. Amy has, and she's considering treatment at the moment. But relapsing disease is not always MS. And you can have MS, you can have MOG-associated demyelination, multiphasic neuromyelitis optica, but there are also others like Clippers, which we know now to be familial HLH, and other disorders. So let me go back to Joel. Remember the 4-year-old that with the sore throat and who we thought had ADEM. And remember he was MOG positive. Well, about 4 years afterwards, I get a call. I think he was a Sheffield patient, can't remember. But I get a call from his pediatrician saying, Joel's presented with seizures and he's wobbly on his feet. And they repeated his scan and he had more white matter lesions. One was in the cerebellum. So he has what we would call multiphasic ADEM. And remember, he was MOG positive as well. So what is multiphasic ADEM? So multiphasic ADEM, we've known it for many years, and we used to call it a bit like, I suppose, spinal MS used to be. Spinal MS is now NMO. It was a subtype. We used to thought was a subtype of MS. What we knew about it is the child would present with ADEM, and then the either would present with ADEM or optic neuritis a few months later, or sometimes years later. The patients were often very steroid dependent. So these were the ones that you put them on steroids, and then as you wean them off, they have a relapse. They often would present with ataxia or seizures or optic neuritis or myelitis. So slightly different than the classical presentation of MS. And then if you give them Rebif or betaferon, it doesn't work. It never used to make any difference to the relapses. We did try that. And then in between, that's the unusual bit as well, so you have the really bad scan, then you get a follow-up scan and it looks normal, and then when they relapse, they have more lesions. The other thing we notice is that after a certain period of having a few relapses, it would almost like burn out. They would stop relapsing. And then now we know that many of these children have MOG antibodies. And so we call it now MOG-associated demyelination. So what is MOG? Well, the problem is with MOG is that about 35% of children with demyelinating disease have MOG antibodies, okay? So it's not as helpful as the aquaporin 4 antibody. So, and many of these children have monophasic disease. I follow up all my children for years and years and years afterwards, and many of these children do not relapse. But some do relapse, and then it's multiphasic. Interestingly, MOG antibodies are not seen in childhood MS. So all the children, we test all our children with childhood MS for MOG antibodies. They don't have MOG antibodies. Also, their clinical features are different. So they have ataxia, encephalopathy, seizures. This is not really a typical presentation for MS. And the MRI pattern is slightly different too. So this is a more kind of typical imaging. You get these really large, hazy bilateral lesions, often involving the cerebellum. And when you've got transverse myelitis, it's a longitudinal, extensive transverse myelitis involving the conus. The problem with MOG, though, is it can give you many different pictures. So it could be monophasic, it could be multiphasic, and it can even be commonly seen as an autoimmune encephalitis. Apparently, it's more common than the NMDA, if you've ever heard of NMDA, but that's sometimes. So it is a bit of a problem, and we haven't really resolved it yet. So I'll just quickly talk about Dan, because he's a 15-year-old boy who had left blurred vision and then weakness of all limbs. and prior to that he had vomiting and nausea. And his scan showed really the classical findings that you have for neuromyelitis optica. You can see here the kind of the spinal changes, the optic nerve changes, and also the brain changes. So neuromyelitis optica, for those who need a reminder, is what we used to call DEVEX, and it's usually children present or adults present with optic neuritis and myelitis, and it's usually a longitudinal extensive demyelination, both in the optic nerve and the spine. It's associated with the aquaporin 4 antibody. It can be monophasic, but particularly if they've got the antibody, most are relapsing. There can be brain involvement, and the brain changes are different to this typical pattern seen in MS. And in children, we use the same Wingershire criteria as adults, which is basically you need aquaporin 4. If you have aquaporin 4 antibodies, you only need one core clinical feature, but if you're aquaporin 4 negative, you need 2 core features to make the diagnosis. It's even rarer than MS. So the diagnosis in children can be a challenge. The differential is even broader than this, and the biggest confusion is ADEM. So this is our differential of demyelinating disease. So after you've got a child who you think has some neurological symptoms, who has an MRI scan that looks demyelination, these are the things we still have to consider. And that varies from genetic conditions, metabolic conditions, malignancies, vasculitis, toxins, and vascular conditions. So it's really broad. It helps to think a little bit in how they present. So if they present with encephalopathy, yes, it could be ADEM. But remember infection, remember metabolic disorders, particularly if they're younger, and genetic conditions that can present with encephalopathy. If they present with focal neurology, as Daisy did, then you need to think about stroke. And I think that's why she had the scan so quickly. I think actually the pediatrician thought she might have had a stroke. Tumours. If they present with a headache like Amy and Heidi did, yes, it could be radiological isolated syndrome, but it could also be non-specific or very long-standing. So if you've had an antenatal, been exposed to an antenatal virus in utero, you can sometimes get these white matter spots, which can sometimes mimic demyelination. If you present with spinal cord symptoms, you've got to think of tumor, particularly if it's very acute, but even things like biotinidase deficiency, which is a metabolic disorder, and vitamin B12 deficiency. And if you present with blurred vision or disc swelling, it could be functional, it could be labours, it could be vitamin A deficiency. You've got to keep your broad in your mind. So these are the clues I use when making the diagnosis. And I'm very simple, actually. But if a child's very young, I always broaden I always do a few more tests. If they're consanguineous family, I think of metabolic conditions. Symmetrical lesions, think of metabolic conditions. Progressive decline, we don't see primary progressive MS in childhood. We do, but it's so rare. I've seen maybe 2 cases over the last 20 years. And we did a big national study where we had 300 patients, and I think there was only 1 patient with a primary progressive MS. So it is extremely, extremely rare. You think if the CSF is normal, then you have to rethink. Resistant MS that doesn't respond to treatment, think again. And if the child has any other symptom besides the CNS, so if they've got a big liver, you've got to think of other things as well. Children only have 1 disease. We don't have, like the adults, multiple diseases. We just deal with 1 disease, thankfully. And these are this is a list of tests that we consider doing. We have first line and second line, and we really tailor it according to the presentation and the imaging. Children are not that easy to investigate, so every blood test you do, you have to justify, because otherwise they will never speak to you again. So why is it so important to get the diagnosis right? I think the main one is to get the right treatment to the child. For the family, it's important because they want to know what is the future. what does this mean for my child? And the other thing is we have a number of clinical trials now for both NMO and for MS in children, and therefore we want to make sure we are enrolling the right patients, because otherwise the treatment may not work because we've got the wrong patient in the trial. So how do we treat? And I looked at this slide. This is an old slide. I think I used the same slide in 2005. And basically nothing's changed much. So we have acute treatment, disease-modifying treatment, symptomatic treatment. And then it was a wish in 2005, and I think it's still very much a wish. Neuroprotective and neurorestorative treatment is still not really happening. And this is actually something that children want and parents want. That's the question I often get asked. So what can we do to reverse things, make things better? And that's difficult. So how do we stop the relapses with disease-modifying treatment? So I've just put in this slide MS Mini, and we'll come back to that in a minute. In neuromyelitis optica, it's been mainly azathioprine, mycophenolate, and rituximab, but there are newer drugs on the horizon, particularly for adults. For children, it's still a bit of a challenge, but we are participating in some trials. But NMO is so rare, it's even harder to get them into the trial. And then MOG-associated demyelination, we don't really know. There are no trials, and it's all based on experience. Most of us know that, for example, the beta-ferrons don't work from experience, but we don't really know how to treat these patients, and we're kind of using the same treatment pathway as those with NMO. So we use MMF, azathioprine, immunoglobulins seem to work, but can't get a hold of it in the UK, and rituximab. So this is the choice of DMTs in MS. It's probably a little bit outdated, but there's loads of choice. And this is the same choice that we can offer our 12-year-olds and older kids. Under the age, if they're less than 12, unfortunately, we cannot give anything but Rebif. There are definitely some tensions in pediatric MS management. And the big one is limited evidence in children. And for years, it was all based on the consensus guidelines. But the international pediatric MS community has really been very active in trying to encourage and to engage with FDA, EMA, and the drug companies to make sure we get some clinical trials. And we have actually now at least definitely, I think at least 4 clinical trials have been published. So they've been recruited to and been published. Poor compliance is another tension, especially when we only had the beta-ferrons and the Copaxone, and there were injections. And patients don't always tell me what happens. I try to be very friendly and not judgmental, no blame, etc. But I'm sure that that many of the children didn't take their drugs. And the people who've done some research in it estimated to be at least 40%. And then, of course, funding restrictions, which have always been a challenge. It's less of a challenge now, but for the under 12, it's still a real struggle. And, I write individual, IFRs, they always get rejected because the 10-year-old is not the only one, and I can't lie to them and say there'll never be another 10-year-old with MS. I've written to MPs, I've done all sorts to get this, but we'll get there. We're working with NHS England to see if we can improve it a bit. So that has really helped because NHS England commissioned the MS management service for children. And they've recommended that we can use DMTs in pediatric onset MS. And so we can fill out blue tech forms and get these children on the drugs that they need. And if you look at it, if the big problem is those before puberty. We just have only got one drug. There's still, limited evidence, and this is what I looked it up last night again, just update the slide. These are the drugs that have got a childhood recommendation. and an age and a dose, but many of them don't, and definitely not the newer drugs yet. Fingo, Tecfidera and Abejo are all based on studies, so the clinical trials that have happened. But for example, Tysabri, there was a clinical trial. It's never got published in children, and it's also not on there. Officially we can't use it. I just want to, and the reason I'm bringing this case up is, this girl up again is as you've noticed, my heart is a little bit worried about all these younger age children, because you as adults talk about early treatment. I talk about early treatment in children too, because actually the younger they are, the more cognitive impairment they get. And so I would like to protect their brain even more in the young age group. And therefore, using Rebif, it's a real ethical question. Should we even be offering this to the children? Because if you look at Daisy, she was started on Tecfidera, moderately effective. She had many relapses, many lesions on her scan, and in 3 years, her brain really shrunk. And so, the question I have is, should we have hit her hard and then, right at the start, rather than this really, we'll just try something moderately effective and then try something highly effective later. It's just a question, that we discuss a lot about, should we not be a bit more aggressive in our treatment approach? Good. So I hope by asking questions and finding answers, we have unraveled the challenging diagnosis of childhood MS. More questions remain unanswered, but it's a start. Thank you. Any questions?